This is the recorded key points from Module I, Assessment of the Abdomen, the GI System. Our abdomen has several layers of muscles. We have the very top layer, which is we call our abs. This is the rectus abdominis. Excuse me. Then we have our external oblique that is right up underneath our abs. Then we have the internal oblique and then the transverse. When you look at a picture of those muscles, you just want to pay special attention that you notice that the muscles run different directions. They don't all run the same directions. And this is to provide that extra protection that prevents penetration and also for movement. Our abdomen is the largest cavity in our body. It begins at our diaphragm and it extends all the way down to the top of our pelvis. It is divided into 4 quadrants. The aorta is midline in the left upper quadrant and it bifurcates at the belly button or the umbilicus area into the right and left iliac arteries. Our kidneys are retroperitoneal. They are posterior to the abdomen. That means they are located more on the back side, and that's how we usually assess those, is from the back. The spleen is a soft mass of lymphatic tissue. It helps act as a filter. Pancreas is located directly behind the stomach. Our pancreas is what helps control our blood glucose levels. It secretes insulin. Then we have the viscera. The viscera is all of the internal abdominal structures combined. The abdominal wall is divided into 4 quadrants by a vertical and a horizontal imaginary line. It bisects at the umbilicus area. And then we have our quadrants. We start at the right lower quadrant, then we will move to the right upper quadrant, then over to the left upper quadrant, and then the left lower quadrant. There are also 3 regions that we will use for documentation and assessment. We have the epigastric area. This is the area above the stomach. Then we have the umbilical. This is the area around the navel or the belly button. And then the suprapubic area. This is right below the navel area, but above the pubis area. It's important for us to know what organs are located in what quadrant. So let's look at the right upper quadrant. In this quadrant, you will have the liver, the gallbladder, the duodenum, the right kidney and adrenal gland, and then the colon. On the left upper quadrant, you're going to have the stomach, the spleen, the pancreas, the left kidney and adrenal gland, and colon. It's important for us to know what organs are located in what quadrants for when the patient or client complains of pain. It will kind of give us an indication of what organ they could be having the problem with. The right lower quadrant, we have our colon, our small intestines, our appendix, females, the right ovary and tube, the right ureter, and the males, the right spermatic cord. The left lower quadrant, the colon, small intestines, the left ovary and tube in females, the left ureter, and for males, the left spermatic cord. When we're talking to our clients about their GI system, we want to make sure we ask about their appetite. If they've noticed any changes in their appetite, the time period and the amount, any changes in weight, whether it's a loss or a gain. We want to know how much and over how long of a time period was the weight loss or gain. And then you also want to ask them, was the weight loss or gain intentional? Dysphagia with a G, this is trouble swallowing. So we want to make sure we ask them if they've noticed any changes in their swallowing. And if so, do they know what caused it? And do they do anything to help alleviate those symptoms? Any food intolerances. You want to know about any types of reactions they have to any types of food, what occurs, what happens when they eat a food that they do not tolerate. You know, do they have heartburn? Do they have an upset stomach or diarrhea? And we want to know about any prescription medicines and any over-the-counter medications, how often they take them, when they take them, and the dosage. We want to know about pain, what causes it, when does it start, the location of it, and the severity. And we want them to describe the characteristics, the quality, and the pattern, associated symptoms. Meaning, are there any other symptoms that go along with the pain, like diarrhea or nausea or vomiting? Eating, does that make the pain better or worse? Are there any other clinical symptoms that they are having? What helps it or alleviates the pain? Is there anything that aggravates it more so? And then again, treatment. What do they take for the pain? Nausea and vomiting, you want to know about the onset, the frequency, the type and the amount, what caused it, what triggered it, and what recent foods that was eaten. And importantly, we want to know about any travel habits. You're going to ask about their bowel habits, the frequency, color, consistency. Do they frequently have diarrhea or constipation? Any changes they've noticed in their bowels? Laxative use, if they use laxatives, what kind, amount, how often? Any past abdominal history. We want to know about any type of GI diseases, any GI diagnostic procedures, and any surgeries that they may have had. Again, medications, you've got to know about the medications, and you don't want to just know about medications related to the GI system. There are other medications that clients can take that can cause GI upset and GI complications. We want to know if they drink. If so, what do they drink, how much, and how often, and smoking history. We want to do a nutritional assessment. We want to ask them to recall a 24-hour diet. This will give us an idea of what types of food that they are eating. You want to make sure you have adequate lighting when you are getting ready to do your assessment, because the first thing you're going to want to do is you're going to want to expose the abdomen and you want to look at it, okay? So you want to make sure that you drape the genitalia area and the female breast, provide them with as much privacy as you can. You want to position them for comfort, but you also want to make sure that you are able to visualize that abdominal wall while it is relaxed. Encourage them to empty their bladder before the exam because you are going to be palpating. You want to warm your stethoscope up. You don't want to place a cold stethoscope on their abdomen because that's going to cause them to guard. You want to make sure you auscultate before you palpate and percuss when you are doing the GI assessment. And you want to make sure that your client stays completely relaxed. As I said, when we are doing a GI assessment, you want to inspect, you want to look at, you want to auscultate, you want to listen before you percuss or palpate. And the reason for this is because we want to auscultate, we want to listen when the bowels are least active. When we percuss and palpate, we are going to activate that peristalsis, and we're going to cause those bowels to become more active, and we won't get a accurate assessment when we auscultate. When we are inspecting the abdomen, when they are laying flat, we want to look at the contour of the abdomen. So we want to stand at the person's side, typically the right side, and we want to look down on the abdomen. Then you want to kind of stoop down and you want to gaze across the abdomen. You want your head just a little bit higher than the abdomen. That way you can get a good visual of the shape of the abdomen. So this first picture is of a flat abdomen. Going across to the right side, this is scaphoid. This is where it is really concave. You'll see this on a frail patient, malnourished patient, or just a really thin individual that doesn't have good muscle tone in the stomach area. Going back to the right side, the left side, left bottom corner, this is rounded. Rounded they can have a little bit of adipose tissue, or they may have disease, liver cirrhosis, that can cause some ascites, that's fluid buildup in the abdomen. But this is rounded, or as some people may call, kind of like a bear belly. And the last one is protuberant. This is a very extended abdomen. It's going to be very extended. It's going to be very firm when you palpate it. Again, this can be caused from just overweight, obesity. It could be from a disease process. We do want the abdomen to be symmetrical bilaterally. The umbilicus is typically midline. It can be inverted. You want to make sure that there are no signs of any type of discoloration, inflammation, or any hernias in this area. With pregnancy, it is common for it to be inverted and kind of pushed upward. You want to make sure that the skin surface is smooth and even skin color. You want to access the skin turgor. You want to assess for any type of pigment change, lesions, or scars. One common pigment change or scar is called striae. This is stretch marks. We want to look for any type of pulsations or movements. This could be the aorta. It is right below the epigastric area. You usually only see this in individuals that are very thin. You want to make sure that your client is very comfortable and relaxed. You want to make sure you're paying attention to their facial expressions, that they're not showing any grimace. Some abnormal signs to watch for during the abdominal assessment is stillness. If the client is laying extremely still and it looks like they're afraid to move, because if they move, they're going to hurt. This can be caused by pain of peritonitis. You want to pay attention to their knees. Are their knees flexed up? Again, are they grimacing? Facial expressions, increased breathing. All of these are signs of pain. And then restlessness. Restlessness can be caused by gastroenteritis or a bowel obstruction. We want to listen for the bowel sounds. You're going to use the diaphragm end of your stethoscope. You are going to hold it lightly against the skin, starting in that right lower quadrant. If you push too hard, you can stimulate those bowel sounds, stimulate that peristalsis again, and you will get an abnormal finding. How we classify bowel sounds is normal, hypoactive, hyperactive, and then absent. Remember, and please note, you do not document absent bowel sounds unless you have listened to that quadrant for 5 minutes. We do not count bowel sounds. It is very uncommon to have silent bowel sounds. As I mentioned, you want to make sure you listen for a solid 5 minutes before deciding that those bowel sounds are completely absent. Bowel sounds, they originate from movement of air or fluid through the small intestines. It is called peristalsis. You can also hear vascular sounds when you're listening to the abdominal area. Typically what you will hear is going to be a bruit, and this is a abnormal vascular sound. There is a small percentage of adults that have bruits. You just want to make sure you note the location of it, and you do not want to palpate that area. Percussion. We use percussion to locate organs and screen for any type of abnormal fluid or masses. You want to lightly percuss in all 4 quadrants, and you want to determine if it's tympany or dullness. Tympany is going to be a more predominantly heard over the abdominal area because we have the intestines located there, and the intestines are filled with air. You're going to hear the dullness. That's going to be heard more over the bladder, adipose tissue, or if there's fluid or a mass present. Hyperresonance will be because of gas. There's going to be a distension of the abdominal area. And then over the sliver and spleen, you're going to hear dullness. We palpate to determine masses, fluid. If there is a mass, we want to determine the size, the location. You want to make sure that your client is relaxed, that the muscles are not contracted during this examination. How we palpate is we begin in the right lower quadrant. You want to use your first 4 fingers, close them together, and depress the skin about 1 centimeter. You're going to make small circular motions. You want to lift your fingers and move to the next area, and we move in a clockwise direction around the abdomen. We are not purposely trying to feel for the organs, but we are paying attention for any guarding or rigidity, pain, or tenderness. These can be signs of inflammation of the peritoneum area. Deep palpation is where you're pressing about 5 to 8 centimeters. This is something that we will not do. This is more for the advanced practice individuals. But the reason for this is again to identify any masses and obtain the size, location, and the consistency. You can assess liver by palpation, although it's not very common. But if you were trying to do this, you would place your left hand under the person's back, parallel to the 11th and 12th rib, and lift up to support the contents in the abdominal cavity. With your right hand on the right upper quadrant, with your fingers parallel to midline, you're going to push down right under that right costal margin. You're going to ask your client to take a deep breath. If you feel anything, you might feel the edge of the liver as the diaphragm pushes it down during inhalation. The spleen, this can be palpated in the left upper quadrant. The only thing I want you to know about this is in order to palpate the spleen, it must be very enlarged. It needs to be enlarged at least 3 times its normal size before you could ever feel it. The way we palpate the kidneys and determine the location is we ask our client to take a deep breath prior to the examination. We are going to form a duckbill hand position at the right flank area. You should not feel any change, or you should just feel a smooth muscle mass. The left kidney, you want to push your right hand deep into the abdominal cavity. Again, you should feel no change with inhalation. It is typically not something you are going to feel on palpation. You do want to make a note that the left kidney is 1 centimeter higher than the right kidney. You can palpate the aorta by using your thumb and opposing finger. It's going to be slightly left to the midline. If you feel a pulsation that is larger than 2.5 to 4 centimeters, this could be a sign of an abdominal aortic aneurysm. Costovertebral angle tenderness. This is how we assess for tenderness or inflammation of the kidneys. You want to place your hand over the 12th rib at the costovertebral angle on the back, and then you want to use your opposite hand and you want to thump that hand with a closed fist. Typically, your patient, they'll feel the thud, but they will not experience any pain. If there is pain, then this is indicative of inflammation of the kidney. We can check the Blumberg's sign. This is also known as rebound tenderness. You want to hold your hand at a 90-degree angle perpendicular to the abdomen. You are slowly going to press down and deeply. Quickly, you are going to remove your hand. Your client should not feel or experience any type of pain. If there is pain upon release, this is peritoneal inflammation, or this is also how we can assess for appendicitis. When we are checking for fluid or ascites, you're going to place the ulnar edge of someone else's hand or your client's hand to kind of give you a midline visual. And you want to place your left hand on the patient's right flank. Use your right hand to kind of strike the left flank. And what you're looking for is a wave that goes through the abdomen area. If you see this, this is fluid, and this is called ascites. When we are assessing the older adults, you will note that there is increased deposits of subcutaneous fat on the client's abdomen and hips. This is because it is redistributed away from the extremities. So when you assess their hands or arms and legs, they're going to be slightly smaller. They're going to start to lose that muscle mass around their abdominal area. So the muscle mass, they may present to be thinner with less tone. So you may be able to palpate the liver and kidneys on these clients. They are going to experience dry mouth more and a decreased sense of taste. They also may experience reflux. This is because of esophageal emptying and gastric acid secretions are delayed. Everything kind of slows down with them. This is just some pictures of some abnormal findings of some abdomens that you may see. This top one right here, this could be ascites. This one right here is a pregnancy. This is just excessive adipose tissue on the bottom right and the bottom left. This could be a hernia. Some common sites of referred abdominal pain. If someone complains of the right upper quadrant, this could be something with the liver. Or if something's going on with the esophagus, they may complain of a burning or hurting sensation behind the lower sternum. If they have an ulcer, they could complain of shoulder pain. Gallbladder is going to be the right upper quadrant, whereas the right lower quadrant, that's where your appendix is, so appendicitis. If they're having issues with the pancreas, they may experience mid-epigastric pain that radiates other places. Kidneys, flank or lower abdominal pain. Small intestines, this is going to be kind of generalized over the whole abdomen. And then the colon, this is going to be more of a colicky pain with bloating. This is a picture of some hernias. A hernia is when the intestines protrude through the abdominal wall. So this is an issue. The intestines can become estrangulated, so they can die, they can lose circulation. It is important that we educate our clients not to push it back through the abdominal wall. Typically, this is resolved with surgery. Sometimes they go in and they put a piece of mesh in to reinforce that area. Some more abnormal findings are the enlarged organs, hepatomegaly. This is enlarged liver, splenomegaly, enlarged spleen, enlarged kidneys, gallbladder, and aortic aneurysm as pictured over on the right. This is where the wall of the aorta becomes weak and it protrudes, and this can rupture. And then we have hernias.